Good afternoon, everyone, and welcome to our webinar, Theranostics 101 for prostate cancer specialist nurses in the field of prostate cancer, brought to you by Telix and the Prostate Cancer Foundation of Australia. My name is Russell Briggs and I work with the Prostate Cancer Foundation of Australia. I would like to introduce you to Danielle Meyrick and Samantha McSherry. Dr. Danielle Meyrick is a practicing medical practitioner holding an MD from the University of Western Australia and also a PhD in radiopharmaceutical chemistry, having worked extensively in the synthesis and early clinical application of novel diagnostic and therapeutic radiopharmaceuticals. Prior to joining Telix, Danielle held the position of Chief Scientist, GenesisCare Theranostics, and was instrumental in developing a special access clinical program and establishing a robust platform of research within the organisation. At GenesisCare, Danielle established a nuclear medicine dosimetry and central imaging service to support the clinical CRO offering. Danielle was previously Global Senior Innovation Technical Specialist at BASF and has held various senior positions in academia, including Deputy School of Dean and the Faculty of Science and Engineering, Murdoch University, and Associate Professor at the School of Biomedical, Biomolecular and Chemical Services, University of Western Australia. I'd also like to introduce Samantha McSherry, who holds a bachelor's degree in science and has previously worked in the United States with Novartis in the area of theranostics. Returning to Australia last year, Samantha joined Telix as a Director of Promotional Operations and is very excited to be promoting Lucix release on July 1 this year. Thank you, Danielle and Samantha.
Thanks very much for the introduction, Russell. Very nice and generous introduction. We appreciate that. And thanks very much to the Prostate Cancer Foundation for the opportunity to present to you today. Really excited and privileged to have the opportunity to talk to a very interested group of nurses about Theranostics. And we've titled this Theranostics 101. It's probably not going to come across very 101, but one thing I would like to emphasise, and I think maybe something just came up in the chat saying just that, is we absolutely welcome your questions at any, well, I was going to say at any point along the way, but the way we'll run this is I will give my presentation and I'll stop at various points, hopefully to answer your questions. Emphasising again, we really welcome the opportunity for questions. So please put them into the chat box as we go through, and I'll stop at various points and address the questions if I can. And also feel free to put some questions to Sam in her role as Director of Commercial Operations for the ANZ region. So firstly, let me tell you a little bit about TLX Pharmaceuticals. Should first of all show you my disclaimer, and you may or may not know TLX Pharmaceuticals, that we have a fairly high profile in Australia. We're an Australian-based organisation where we had our genesis in Melbourne, Australia. And as the world map shows you there, we now have a presence all over the globe. We have offices in Indianapolis in the United States, in Geneva in Switzerland. We have an office in Kyoto in Japan, and also in Liège and Brussels in Belgium. But in addition to those physical spaces and physical offices, we have employees all over the globe, which is very fortunate for us, meaning we're able to I guess, employ the experts from wherever they happen to be around the world. So really fortunate situation that we're in. As is written there, we are a global leader in radiopharmaceuticals. We're probably one of the oldest radiopharmaceutical focused pharmaceutical companies globally, so established in 2015. Which is not very old, but we do focus exclusively on radiopharmaceuticals for cancer therapy and rare diseases. And the exciting thing for us now is that we are now a commercial stage company. So you would all, I think, appreciate the excitement within a company and the various changes that take place as a company moves into that commercial space, which is obviously for many reasons good. One of those is that this is the commercialization of our Lucix product, as Russell mentioned, which is our prostate cancer imaging agent, PET imaging agent. And I think many of the nurses on this call will already be familiar with that agent, but I'll talk to you a little bit about it as we move through the presentation. But this, the commercialization comes off our FDA approval for a Lucix. So this product was approved by the FDA late 2021. It was a Christmas present for Telix, and a very, very welcome Christmas present. So that commercialization means access to patients in the US to this agent. It's one of a couple of registered PSMA targeting agents in the US. And the product's also been registered by the TGA in Australia. So again, fantastic for patient access. Fantastic for us because of that. That's obviously very important for us. But being a commercial company now means we're able to drive forward our development programs in our other agents. So you'll see in a moment in the Theranostics 101 that we're developing agents for prostate cancer therapy as well. We've administered quite a number of doses prior to commercialization of this PSMA targeting agent. There's a number there, 13,200 in the last 12 months. This is through magisterial use and special access programs in Europe and to some extent Australia, and also through investigator-initiated studies. So we've got some really good track record. We understand the agent very well. We have a number of clinical studies with Lucix, with our PSMA PET agent. 20 clinical studies are run across a number of indications. And importantly as well, as a point of difference with our gallium PSMA PET imaging agent and other PSMA agents, we have a really strong global supply and distribution network. So, and you know, I guess our track record, we are now developing in the US with really robust supply networks, and then likewise in Australia, we'll have the opportunity to do that very soon. And Sam, maybe you'll talk about that a little bit later on. So really important time, great for patients, and you know, you can imagine we're very excited about offering this PSMA PET agent to patients. So to get on to what Theranostics is, we talk a lot in Telix about seeing the disease and treating the disease. And this is what underpins Theranostics, the capacity and the capability to see a lesion, see a cancerous lesion, and then treat that lesion very specifically with radioactivity. So the idea is, if you have a look at this image on the left, you would probably be aware that cancer cells very often will express molecular signatures that are either different to molecular signatures that are expressed in healthy tissue, and they're different because they play a part in, generally speaking, because they play a part in the growth of the cancer. So they either express those different molecular signatures and biochemical markers, or they express biochemical markers that are also expressed on healthy tissue, but they express them to a much greater extent or with a higher density. So Theranostics uses that fact, it exploits that fact to target radiation directly to a tumor. So the cancer will express a particular signature, as I said, and then we design molecules that will bind to that expressed signature, and then to those molecules that bind to the biochemical marker, we attach a radioactive isotope, as I mentioned, and then that carries the molecule that binds to the marker carries that radiation directly to the tumor. And we can do different things depending on what radioisotope we attach to that molecule that targets that overexpressed biochemical marker. So if we attach radionuclides, radioactive agents that emit positrons, so are positron emitters, and you would be very familiar with PET, positron emission tomography. So if we can attach an isotope that is a positron emitter, then you can imagine in fact, you don't need to imagine, I'm sure you've seen these gallium PSMA PET images. This is how we manage to visualize, in the case of gallium PSMA 11, prostate cancer lesions that have the molecule attached and are emitting the positron from the gallium. So gallium-68 is one positron emitter that we can use in this context. We can also use zirconium-89, which also emits a positron, which is then captured by the detector on a PET scanner and also then enables the imaging of the cancer. And there are a range of positron emitters that we can use for this purpose. Now you can imagine that there are certain features, if you sort of take your mind back to your early chemistry days and physics days, isotopes have different half-lives, they have different chemical behaviours. And so even though we say, and I think I may have just said it myself, you know, any positron emitting isotope we can use, that's probably a theory more than it is a practical reality, because not every positron emitter will have the half-life that is suitable, you know, will have the chemistry that is suitable for our agents, or indeed will be necessarily in abundant supply. So this brings us to another question, is that there are some isotopes that we know in theory would do this job very, very well, but are not necessarily in abundant supply. And you can imagine there are manufacturers and isotope suppliers working on those issues. So those are the imaging isotopes, the positron emitters, generally speaking. There are others, but let's think about this in terms of positron emitters. And if you have a look over here, we see an image from our TLX 591 CDX, which is now Lucix, our commercial agent. And this, you can see, very clearly shows metastatic disease in this patient. So these bright spots, you will have seen them before, I'm absolutely certain, show that this patient has metastatic disease in the vertebra of the spine and some disease in the sternum. Everything else looks okay. That's what we would call physiological uptake. But you can see how this is a really powerful imaging agent. And then to come to the therapeutic component of Theranostics. And the principle is exactly the same. We exploit the overexpression of the biochemical markers, the overexpression of these sort of rogue chemicals. I mean, they're rogue because they're expressed only by the cancer or overexpressed by the cancer. We use the same targeting molecule, this part here, but we attach a different isotope. And we attach, in this case, either a beta emitter, a beta minus emitter, not a beta plus, which is a positron, so a beta minus, or an alpha emitter. And beta minus and alpha emitters have therapeutic qualities. So they emit their energy, emit their radiation, deposit it in the tumour, and in doing so, effectively destroy the tumour cells with minimal collateral damage to the healthy tissues around the tumour. So you can see we have the potential to very accurately and precisely target the tumour. So these same lesions that we see on the image are targeted by the therapeutic isotope. So we're very selectively able to target radiation to the tumour and to kill off the tumour cells. And so here's an image here of our agent in development for therapy of prostate cancer, TLX 591. So it's the cousin of the imaging agent. And it's an antibody bound to lutetium with its therapeutic qualities. And you can see lutetium can actually be imaged quite well, lutetium-177, not as well as a positron emitter. So the image is a bit fuzzy, but you can see all these black spots everywhere, which is metastatic disease in this patient. So, but also is reassuring when we see that image, because we know we're delivering radiation directly to the tumour. So I might pause there for a couple of minutes, and there are no questions coming up in the chat there, Russell, but.
No, there's no questions come through on the Q&A as yet either. So if you want to continue.
Yep, yep, I will. I'll keep going. So again, just to, I guess, bring home in a pictorial representation exactly what it is that we do with Theranostics. So again, we've talked about see it, treat it. We also talk about taking radiation from radiation in a box in the form of a linear accelerator, a LINAC. This device here, which delivers radiation externally. And this is what we all, I think, still think of when we think of radiation. We think of external beam radiation, which has now, of course, progressed quite significantly in the past decade in terms of the technology, and is now itself quite precise, but still not as precise as this internally administered radiation in a shot. So we're moving from a box to a shot, external radiation to internally delivered. And we have this synergy between imaging and therapy. As I said, we can image the lesions, and we know that when we use our therapeutic isotope, we're targeting the very same lesions. We have the opportunity to treat a really broad range of cancers with these agents, because we, again, if we go back to the original principle, we're exploiting the overexpression of certain biochemical signatures and markers. So broad cancer utility. We can work together with existing drugs to boost the utility or the efficacy of those existing drugs. We have the opportunity, I won't go into it in any detail at all, but we have the opportunity to enhance the efficacy of immunotherapy, and you would all be aware of the increasing application of immunotherapy. And so by selectively delivering radiation to a tumour, we can potentially sensitize that tumour to the effects of immunotherapy even more. And we believe that this will be a cornerstone for future cell and gene therapy also. So we really believe, and we're not alone. I mean, you would, I think, all be aware of the various companies that are now operating in this radiopharmaceutical space and developing radiopharmaceutical agents, that this is an important addition to the usual treatments of surgery and, of course, men with prostate cancer. The great majority of them, you know, they're usually caught when the disease is localized, so the great majority of them will have a prostatectomy. So surgery is a big part of the therapeutic regime for men with prostate cancer. So we have surgery, we have radiation oncology, medical oncology, and what some people describe as nuclear oncology or radiopharmaceuticals. And the radiopharmaceuticals are a therapy in themselves, but they also play an important role in the imaging, as I've described. So an important fourth pillar in oncologic treatments. So let me go to our pipeline. I don't want to talk through this entire pipeline. We are focusing on prostate cancer. I guess really what I wanted to call out to you is that we're very, very active in the development of prostate cancer agents. So we have our imaging molecule, which has now proceeded all the way through phase 1, phase 2, phase 3 studies and is now commercial. Exciting times. I mentioned to you our therapeutic, which will soon enter phase 3 clinical studies, which is bringing us then one step to patient access. I'm going to talk a little bit more about patient access to this agent prior to commercialization. We have an alpha labeled antibody, PSMA targeting antibody that we worked on. So 2 slides ago, I mentioned to you beta emitters and alpha emitters have really fantastic therapeutic, not just potential, but realistically, they give very good therapeutic efficacy. So we have an alpha agent we're also developing. We have a technetium labeled agent. So you would, I think, be familiar with SPECT imaging with technetium agents, bone scans and other things. You absolutely would be familiar with bone scans. And we have this agent that we're developing for as an adjunct in surgery, a little bit like sentinel lymph node detection for breast cancer. Same type of a concept to be able to detect during surgery radioactive lymph nodes for patients having a prostatectomy, so that they don't necessarily need to have a radical or an extended pelvic lymph node dissection with the concomitant side effects that come with that, to be able to target the metastatic lymph nodes during surgery and take those out only. So we're developing that. We have a fluorescent molecule with a similar application in prostate cancer. And incidentally, just coming back to this techie labelled agent, so I mentioned the surgical application. We also are developing that. In fact, it is developed for SPECT imaging as well, in the usual sense of a SPECT imaging agent. So there are prostate cancer agents, and I'm going to talk to you more about the therapeutic in a moment. But I think it's also worth knowing, I mean, this is a prostate cancer talk to the prostate nurses of the Prostate Cancer Foundation, so it makes sense that I should focus absolutely on prostate cancer, and it is a big focus for us. But I mentioned to you earlier that there is broad applicability of theranostic agents to other cancers, and that's reflected in our pipeline as well. So we're developing agents for clear cell renal cell carcinoma, actively developing that agent. You can see where we are in terms of the development. We're developing an agent for imaging and therapy of glioblastoma, GBM, for which at the moment there are very few therapeutic options. We're developing that agent, and we also have an agent that's fairly new in our pipeline, imaging and therapy, with a number of potential applications. Imaging of infection is one with the imaging agent, and then the therapeutic is very likely to have applications for hematological cancers with current quite significant unmet need, and we've had some really exciting early phase data. So really exciting pipeline, but as you can see, we're most advanced with our prostate cancer therapies, prostate cancer agents. I won't labour on that slide, but this is a maybe slightly messy representation just to again bring home that point that Theranostics is a modality that has applicability across a range of cancers, and also to demonstrate that we are absolutely active in terms of our clinical studies globally in developing these agents. So let's now go to the prostate cancer program. But Russell, any questions? I was promised questions.
There was one question asking about if you could chat again briefly about how the Theranostics can help sensitize tumours to immunotherapy. I
can. Yep, I can. I'm happy to address that now. So maybe I'll just go back to the, oh no, I can't. Back to where I mentioned that. Here it is. Yep. Important primer for immuno-oncology. So let's just talk very briefly about immunotherapy, which is absolutely not my area of expertise at all. But I think that we would all be aware that the response to immunotherapeutic agents is very good for patients who do respond. And I think, the response rate, if we take just lung cancer as an example, is about 20%. And melanoma, I think, is about the same, 20%. So patients who respond absolutely beautifully. But eventually what happens, and it was described to me in exactly these terms in the context of melanoma, is that the melanoma, metastatic melanoma will virtually disappear in those patients who do respond, but that it comes roaring back. The term used with me is roaring back. So when it comes roaring back, that's generally because the melanoma has stopped responding to the immunotherapy. And so the idea with irradiating those tumours that have stopped responding is that you activate what's called the STING pathway. I know nothing more than that. That's what it's called, and it's a biochemical pathway, and there are then a whole lot of immune sensitizers that are released in the tumour microenvironment in response to that. So the STING pathway is activated. So and then the tumour becomes once again sensitive to immunotherapy. So that's what we mean by priming the tumour to the immunotherapy. So that's when in patients who have now begun to fail immunotherapy. But I think you can intuitively understand that there is potential to improve the response rates to immunotherapy in that, maybe 80% if you were talking melanoma of patients who don't respond, by applying the same principles, by activating that STING pathway by that targeted delivery of radiation. So the way that this is currently done is with external beam radiotherapy. And the concept with Theranostics is that, you can see, I think, very clearly that there is greater potential to deliver more radiation in a very targeted way to activate that pathway. So that's the concept. I hope that answers the question, but if not, thank you for the question.
We just had one other question come through, which was, how far away do you think is intraoperative use to detect positive lymph nodes? And do you think it would be something that would be widely accessible?
Good question as well, and thanks for the question. We really appreciate it. So we're working with a company called Lightpoint Medical, and Lightpoint Medical have a device that's a probe that is used in conjunction with the robot, the Da Vinci robot, which, even I would say, I mean, time moves very quickly, but in my mind, less than 10 years ago, a Da Vinci robot was sort of considered a highly specialized device that only a certain number of urologists could use. And I have spoken to urologists in recent months who have only ever used a Da Vinci robot. So in a decade, we've gone from it being highly specialized to now it is what people use. Yeah. And in fact, there are some urologists, and this is a long way to answer the question, by the way, but I am going to get to the answer. There are some urologists who would just never consider doing anything other than a robot-assisted surgery. So why am I talking about robots? The device that Lightpoint Medical have is designed to work with the robot, which is why we've partnered with them, because it's, they're right at the sort of cutting edge of where robotic surgery is. And the robot and the device is used in conjunction with our TLX 599, our technetium labeled agent. So we're working in clinical studies with Lightpoint Medical. So we have a phase 2 study that we hope to get underway before the end of the year. So phase 2 study leads to phase 3 study, and then widely available. So, within a sort of a 5 to 8 year, which sounds like a long time, but that's the reality of it. In 5 to 8 years, you can imagine that it will be commercially available and widely used. So that's that part. But to come back a couple of steps, one of the delightful things about being in Australia and being in radiopharmaceuticals, as you may know, and doesn't apply only to radiopharmaceuticals, it applies more generally, is that we have the opportunity to offer some of these things to patients, or clinicians do, to offer some of these things to patients compassionately. And so we are working with the Peter Mac on facilitating compassionate access to the imaging agent, or the detecting agent, the TLX 599 we call it, and Lightpoint Medical are offering compassionate access to the probe, and we expect that we fully expect that we'll be doing, that the urologists at the Peter Mac will be doing compassionate use cases. We'll start at the Peter Mac and then we'll expand. So that will be before the year ends. So that's actually something I think that is important to communicate to your patients as well, because that these things drive each other. So to sort of drive awareness. And I should also say urologists are, you might imagine, incredibly keen to be able to get their hands on this tool that gives them more information during surgery and directs their surgical excisions. So exciting times there as well. All right, I'll move on to prostate cancer program. So on the topic of that technetium labeled agent, the TLX 599, I mentioned to you previously, and you'll be aware anyway, I think most of you, that the technetium 99M labeled agents are not PET agents, so they can't be imaged by a PET camera, but they can be imaged by a SPECT camera. And we know that SPECT cameras are more readily available than PET cameras. I mean, that situation is sort of very slowly changing, I guess, but certainly in Australia, there are far more SPECTs than there are PETs. That situation is also the case elsewhere in the world. And in particular, SPECT cameras what you will find more often than not in a regional and rural setting than a PET camera. So you may have a patient in, let's just say, you know, I live in Western Australia, so you may have a patient, you know, in the far northeast of Australia, or the mid-northeast of Australia, on a station out there somewhere with prostate cancer, who needs an image, and chances are he's not going to very willingly, if we know Australian men, my view might be wrong, but he's not going to very willingly travel to Perth for a PET scan. So we then have an absolute mission to offer our SPECT agents to imaging facilities in rural and remote regions, so these patients can access a SPECT imaging agent and have a SPECT scan of their prostate cancer. So it does the very same thing as our Lucix compound, that is the gallium-68 PET imaged compound. The very same thing. It targets PSMA, but it's, I guess, I hesitate to use the word limited, but it is limited by the SPECT technology and the resolution of a SPECT camera. So we can't image lesions, you know, of the same order of magnitude in the downwards direction. We can't image tiny lesions, but we can image large lesions and get a good sense of the patient's, the state of the patient's disease. And we can certainly tell whether a patient has localized disease or metastatic disease, and all of those important things that then inform treatment decisions. So really important tool for regional patients. Now, the one thing I want to say in relation to that is, I use the word limited in the context of SPECT, but the SPECT technology, the cameras and the detectors themselves and the, I said detectives, the detectors themselves and the software are also constantly improving. And for the technologists that know how to get the best out of the cameras, which is most technologists, particularly in rural regions, you can imagine, and regional areas, they really know how to work those cameras. We are seeing some really fantastic images that, you know, almost performing as well as the PET. So that's a mission. So we have, and we call this our noble registry, the Nobody Left Behind registry. And we offer, you know, we're making this available at no cost to the patient. And I'll get to some of the people involved in that in a second. I already mentioned that we have our alpha therapeutic, and I've already mentioned our image guided surgery. And what's not in here is our lutetium labeled agent, because I'm going to talk to you about that in a tick. So here's our noble registry. I've mentioned to you that it's running here in Australia, but it's a global registry. So we're working with various countries and various sites around the globe with exactly the same purpose as what I've described, facilitating access to this agent for patients that are unable to access a PET scan. And on this slide, you see some of the nicest people that you will ever know around the globe. And some of you may know Pete Tuali. He's an imaging, he was a technologist, and he now has an imaging facilities in Geraldton and Albany and Kalgoorlie. Very enthusiastic TLX 599 techie PSMA user, and he's done some actually really nice things with the agent and produced some really nice images. So if there is any interest in I guess talking about this further with patients in these rural and remote regions, I guess I encourage you to be in touch with us or Pete. And also we have Jeff Curry. I don't know if anybody knows Jeff Curry at Charles Sturt. He's also very active in this space. So really exciting registry actually for us. Lucix we've mentioned, so that's the gallium PSMA, the PET correlate of the SPECT agent. Sam, when I've finished, I might just ask you, in fact, why don't you come in now? Do you want to just talk about the availability of
Sure.
Lucix?
Yep. Thanks, Danielle. So I just wanted to tell you, Lucix is it is indicated for either initial staging or patients with biochemical recurrence. So it has got 2 indications. We are in the process of going off to try and get a 3rd indication for Lucix to make it available to stage birth therapy as well. So we'll keep you posted on that. But as of July the 1st, Lucix will be available in Australia through the GMS network, or the Global Medical Solutions Network. So sites can either get a unit dose from the Global Medical Solutions radiopharmacy and sent to the nuclear medicine, or nuclear medicine departments can actually purchase the cold kit and compound in-house as well. Lucix is a multi-vial, multi-dose vial, so sorry about that, which means that, you know, the demand there, we can get more patients through, right? And this is what we want to do. The reason we chose July the 1st is that we did want to coincide with the MBS reimbursement date as well, because obviously we want to make sure that every patient has access to a Lucix and not be out of pocket. We've heard some stories along the way. Some of you are probably very familiar with Will McDonald, that has also helped us with some speaking engagements and told us his stories. And we all know that some patients just don't have that kind of money to get their scans. So it is going to be readily available come July 1st. So unfortunately, GMS only has radiopharmacies in the major network, the major cities. So, but we're still available. If there's a PET camera in Cairns, absolutely, they can purchase this product and they can still have a PET imaging scan. I think that's pretty much quickly it.
Okay. Maybe time for questions.
Can you just run through again the 2 current indications and the 3rd indication you're looking for? There was just a question came through.
Okay. So, God, I'm trying to think of the exact wording right now. Danielle, do you know the
I can do it. Yeah, I can do it. I've got the exact wording. So it's patients who, at initial diagnosis, as Sam said, who are at high risk of metastases and are candidates for definitive therapy. So that's the first one. And then the second one is patients with suspected recurrence based on elevated PSA. Huge number of patients. And then the indication that we're seeking is selection of patients for theranostic therapy. So for this type of therapy that we're talking about here.
Thank you for that.
Great, thanks for the question. Thanks, Sam. All right, actually this slide, what I wanted to say is, again, I mean, look, and I think everyone on this in this webinar would know that PSMA PET is, I mean, it's been around in Australia. Well, I was about to say available in Australia, but it's only been available to patients who've been able to pay for their scans, as you've said, Sam, who've been able to afford that out-of-pocket expense. But it has been there and in use, but it's only recently been incorporated into the guidelines. And when it was initially incorporated into the guidelines, it was sort of placed after CT and bone scan. But the guidelines have recently been updated to put gallium PSMA as an alternative to CT and bone scan. And then I think it will only be a matter of time before, in fact, it's the scan, or, you know, but it certainly is seen as a complement to CT and bone scan, and is now approved and readily available. So I wanted to highlight that it is incorporated into the guidelines. So
can I just add one thing? I also wanted to state that Lucix is the first TGA approved, which is also on the ARTG listed. So I just wanted to reiterate that, because obviously you might know that some institutions are probably doing compounding in-house, but this is the first registered product in Australia.
Good point. Okay, so let's talk just really quickly then in the last, say, 15 minutes or so on the therapy, the prostate cancer therapy. So as I mentioned to you before, this targets the same overexpressed molecular signature that the imaging agent does. So it targets prostate-specific membrane antigen, which is overexpressed by prostate cancer. It is expressed by healthy prostate tissue, but overexpressed in prostate cancer, and is even further expressed by, generally speaking, by metastatic disease and by more, in inverted commas, aggressive prostate cancer by up to 100-fold, in particular by the metastatic disease. So the PSMA is the target for our therapeutic and for our imaging agent. And just incidentally, as a side but important point, the name is misleading because it isn't prostate specific. It is also expressed by salivary glands, by the GI tract to a certain extent, and they're probably the main other healthy tissues that express it. I'm telling you that for an important reason that we'll get to in a moment. So we've got PSMA overexpressed by prostate cancer. We're developing an agent that targets that tumor-specific PSMA. And as I described to you in the first slide or the second slide, we have a molecule, as I said, targets that, and then to that molecule we attach a radioactive element, and that radioactive element is lutetium-177. So that's what we call at the moment in development TLX591, and behind that we have TLX592, which is the alpha therapeutic, and we have studies ongoing that are developing this agent. This should in fact be Prostate Select study, phase 1 in Australia. That's one of these ancillary studies. We'll very, very soon start Prostate Global. So our ancillary study is recruiting in Prostate Select. We have another study starting very shortly in Australia, Prostate Target, and then we'll move to our confirmatory study, which was phase 3, our pivotal registration study. TLX592 is currently active in WA only at the moment, soon. So, and when I say WA, I mean Perth, and will soon be active in Sydney. And this is the phase 1 for the alpha therapeutic. Why don't I go to the next slide? Now, you will be, I think, very familiar with PSMA targeted therapies. You would be aware of the Novartis approval for Pluvicto in the US, probably 2, maybe 3 months ago now, 2.5 months ago. And you may be asking yourself, what is the difference between the Novartis agent and the agent that we're developing? And the difference is that we are developing an antibody, and the Novartis and some of the other agents are what we just generally call a small molecule. And then you might ask yourself, well, what does that matter? What does it matter if it's an antibody or if it's a small molecule? And the key is in the different sort of biophysical behavior that a small molecule has relative to an antibody. And one of the important features relates to those non-specific, non-tumor specific expression of PSMA that I mentioned to you before. So if we go to this next slide here, we have an image on the left of our antibody biodistribution, so the biodistribution of the radioactivity of the antibody. And then on the right, this is in healthy tissue, by the way, we have the small molecule. And you can see very clearly that there are some differences in terms of the biodistribution. If you look at the black, the black spots here. So we have the salivary gland uptake for the small molecule. We have the renal uptake for the small molecule. So all of these small peptides, regardless of the cancer that you're targeting and the overexpressed biochemical that you're targeting, if you have a peptide, if you have your radioisotope bound to a peptide, it will be cleared pretty quickly by the kidney. It's excreted really, really quickly. So we've got this kidney uptake, and then of course we've got excretion via the bladder. For the antibody, we have no, it's actually not the greatest image because you can't see the full head, but we have no, I think you have to even take my word for it, we have no salivary gland uptake. We have clearance by the liver, so the antibodies are metabolized by the liver. GI tract, of course, liver and GI tract. So we've got the excretion via the GI tract. We don't have that kidney uptake, and you don't see anything here in the liver. So what are the implications of that? Well, the implications are a few, and let's talk about what it means for the patient. So we don't have the salivary gland uptake. You can imagine if you're having repeated administrations of radioactivity that's taken up by the salivary glands, you're ultimately going to harm the salivary glands. And in very extreme cases, for patients who've had multiple doses of the small molecule, these patients end up with xerostomia or dry mouth. Now, in isolation, you might say, well, that's possibly manageable. But the ultimate effect is, and again, I think you'll appreciate this, is that what these patients are able to eat becomes limited. And so they start to lose weight, they don't enjoy their food, you know, there's a significant quality of life implication. They also, in many cases, get dry eye. So that's a really significant patient comfort factor. The other really significant implication, and I think maybe it's on my next slide, is yeah, I mean, I actually prefer looking at the other image, but because we don't have this renal excretion, which is, as I mentioned to you before, rapid and also copious. So up to 50% of administered activity with a small molecule is excreted via the kidneys within the first 4 to 5 hours. So this means if you're giving a patient, you know, a dose of 7 gigabecquerels, the unit of radiation, and the kind of rough dose of a small molecule, 3.5 of that is gone and in the sewage system within the first 4 or 5 hours. So that's not nice for the patient, and it means, you know, we need to encourage the patients to drink a lot and void as frequently as they possibly can in that first 5 hours to flush that through the kidneys. There's a cost implication, there's a waste management implication, there's a nursing implication because you are managing a radioactive patient for longer, well, it is longer because they have a higher dose. I'm going to go back to our administered activities in a second. But you're also, of course, with prostate cancer patients, they're often incontinent. So all of a sudden you have, you know, radioactive urine that you need to handle, whether it's in the toilet or whether because of incontinence, the patient's, you know, has a catheter or some other continence managing device. There's that to handle as well. So there is a nursing implication, there's a patient implication. So with our agent that is cleared via the liver, metabolized via the liver, we avoid all of those implications. And then the sort of additional cost implication is because we're not having that excretion via the kidney, because we're having very specific tumor uptake, we're able to administer a much lower dose to the patient. So I mentioned to you 7 gigabecquerels for a small molecule. That's roughly what it is. It's actually slightly higher than that, as you may know. And usually 4 administrations, so 4 times 7, about 6 to 8 weeks apart. That's the usual regime. And some patients will have more than that. You know, you might speak to nuclear medicine physicians who've given up to 12 administrations, which is great. It means that the cancers respond to these very targeted therapies, but you can also imagine the effects for the patient in terms of the dry mouth and the other side effects. There's some back pain as well. And then potential toxicity to the kidneys when you've got all that, that radiation being excreted. So 7.5-ish, 7 to 7.5 for the small molecule versus for our antibody 2.8 gigabecquerels. So we have 2.8 gigabecquerels and 2 administrations rather than 4 as what we consider a treatment course. So 2 14 days apart for the antibody versus 4 6 to 8 weeks apart. 2.8 gigabecquerels, 7 to 7.5. So those are the differences that we see because we're using an antibody versus a small molecule. Now, the other differences are in relation to the potential toxicity profile. And the big difference here is that an antibody has a much longer circulating half-life. That's the nature of antibodies. And because of that, there is a higher potential for toxicity to the bone marrow. And so what we have seen in our phase 1 and 2 studies, and we see in our current phase 1 study for different purposes that we're running here in Australia, is that there are changes to hematologic parameters. So patients most significantly, and when I say significantly, I mean most predictably in all patients, and the response is predictable. There's a reduction in platelets, so patients become thrombocytopenic, but as I said, it's a predictable decline with a predictable recovery. So the nadir is generally at about 45 days, and most patients recover to 90% of their baseline platelets at 8 to 9 weeks post-therapy. So predictable recovery, also some noticeable changes to red blood cells and neutrophils as well. So the pattern seen across the cell lines, all the blood cell lines, but as I say again, predictably. And if you talk to a medical oncologist or a radiation oncologist, they're quite comfortable with that type of side effect profile for an anti-cancer agent. They're used to seeing that type of side effect profile. They're used to managing patients with that side effect profile. So based on the discussions we've had, we feel pretty comfortable with what we're seeing.
Danielle,
So
there's a couple of questions that have
go
come
for it.
through, if you don't mind.
Go for it. Yep.
One of them is for TLX 591.
Yep.
Is there a threshold limit for patients with abnormal liver function profile to be considered eligible for that treatment?
Yep, there is, and I cannot remember exactly what it is right now, but as with all studies, and I'm happy to provide that information, as with all studies, there is a limit on all the organ functions. So we need, and you could imagine we're paying particular attention to the hematological system as well. So I'm happy to send that through.
Thank you. And another question was, are there any cases in which a patient would not be suitable for TLX 591 compared with small molecule?
There are. I mean, this is only in theory at the moment, remembering that we're still developing this agent, but and the answer to this could change in a year or 2 years' time. But at the moment, because of that potential for the thrombocytopenia that I've just mentioned, if we have patients with coagulopathies, they were excluded from our studies. Patients who are on NOACs and other anticoagulants, we exclude them from the studies, and not for any reason other than, as I said, theoretical, and we want to manage the risk as best we can. And of course, patients who are taking aspirin, and there are a lot of men with prostate cancer. Not a lot, there are men with prostate cancer taking aspirin, but what we advise is that they just come off their aspirin while they're having this treatment. Aspirin is not the problem as much as the NOACs and other things. And look, it may transpire that that's not a problem, but for our development, we want to exclude those patients from the study. And so to go to where we see this agent in future, post-development, I can't see any patient who wouldn't necessarily qualify for our antibody treatment if they also qualified for the small molecule. And in fact, we believe that we will see efficacy with our antibody in patients that have stopped responding to small molecule. So there is an interesting study that we will undertake to explore that. Just seeing that there's only 4 minutes. And one thing I really want to make sure I do raise here is that this is an investigational agent right now. As I've mentioned, we have studies that are currently underway, but I mentioned to you also, in the context of TLX 599, that for us at Telix, it's really an important part of our mission and important to me personally that we offer this compassionately to patients under the TGA SAS scheme. And it's important that we do it, and therefore we do. So I think, you know, I would encourage the nurses and all of you on this call to communicate that out to the various clinicians. We don't, obviously we're prevented from dealing directly with the patient. It needs to come via a clinician. They need to do it, you know, through the clinicians that's managing them. It's not to say we can't receive inquiries from patients or directly from nurses, clinicians, whoever it may be, and we channel those inquiries accordingly. And of course, not all patients will qualify. So there are, of course, certain criteria to qualify for the TGA SAS scheme, but it is certainly available for patients who have failed other therapies or are not candidates for other therapies, whatever they may be. And typically, of course, in the advanced and metastatic setting.
I think there was one more question, Danielle.
Yep.
Fecal excretion SE for Telix 591, what are they?
No. So there's no. So you might think it's the colitis or some other problem. We've seen absolutely nothing in patients to date. So it's excreted, but that's it. It's excreted, out it goes. No problem. GI tract's pretty tough, and it moves through pretty quickly. So I know we're going to get just absolutely booted off as soon as we hit the top of the hour. So I just want to make sure I get the time to say thanks very much again for the opportunity. I've enjoyed it. There's another message coming in, and that's from you guys. That's obviously Sven putting that in there. Please contact us with any questions at any time. We're always happy to receive questions and follow up with you.
Thanks, everybody.
Russell, thank you.
Thank you.
Thank you, Danielle and Samantha, on behalf of Prostate Cancer Foundation of Australia, for this insight into theranostics for our specialist nurses.
Pleasure.
Great. Thanks.
Thanks.
Enjoyed it. Thank you.
Thank you.
Thanks, everyone. See you later. Bye.
Bye.